Hello, I'm Dr. Alexandra Ginty. I'm going to talk to you about discovering my BRCA mutation and really the fallout of what happened. Uh, I'm a family physician and I've been in practice 25 years. And I was 47 in the middle of my career when I was diagnosed with breast cancer. Actually, it was bilateral breast cancer. First, it was a lump that I palpated, and a week later, I was put into an MRI where they found a second tumor, and that also was diagnosed as cancer. And I was scheduled for a bilateral mastectomy with reconstruction and bilateral sentinel nodes, which ended up being an axillary dissection on one side with some nodal involvement. In the waiting room when I went to oncology, I was given a lot of surveys. The surveys were mostly about whether I'd had a history of breast cancer in my family, and I didn't, not as far as I knew. And it was only a little bit later in the process of my chemotherapy that I asked the oncologist, don't you think it's really unusual to have two different cancers? One was invasive ductal carcinoma and the other invasive tubular carcinoma. And he says, yes, actually, you do qualify for genetic counseling. And at that time, I didn't really think I had any family history. But the genetic counselor asked me to go and fill out a family tree, which is a very interesting exercise as your parents, sometimes there's hidden stuff where there's trauma. And in my father's side, his mother died young and it was very traumatic. She was sent home from hospital and she hemorrhaged, and his father couldn't handle it, so he had to deal with it as a young boy. And he had the death certificate, so we had to fill these in with the family tree. My mother reminded me that my cousin on my father's side had ovarian cancer. So when we pulled up the death certificate of my father's mother, who had died young, it was actually inoperable ovarian cancer that she was diagnosed with. And the most difficult thing to hear is that my father said, he said that he knew his mother was going to die. She said she knew what was going to happen because both of her sisters had exactly the same thing happen to them, and they had both died of exactly the same symptoms, and they had ovarian cancer too. So this was pretty life-changing for me as a physician and professional because I knew exactly what it meant. It meant this was a very hereditary thing, and the genetic counselor was absolutely right. This was going to be genetic. I was advised to have my ovaries removed, which of course involved the tubes, but the oncologist asked to have a full hysterectomy because of some of the aromatase inhibitor effects on the uterus afterwards. So that went ahead, and I had all of that done 6 weeks after my last chemotherapy, as well as being put on aromatase inhibitors, which is a pretty drastic level of estrogen drop, before I went back to work 6 weeks later. Because it's hard as a professional to have locum, and it had been almost a year, so it was time that the locum had to move on. I think some of the questions that come up is how this affects my practice. How does it affect my approach to medicine? Honestly, some of the lessons I would say is that from what I've experienced and the lessons, I would make sure you listen really well to the family history. Think of some of the possibilities of cancers that are linked together, like with the BRCA, where you've got the breast and the ovarian in a BRCA1, and in the BRCA2, where you might have a pancreas and melanoma, and a prostate in particular, which my uncle died of of prostate cancer, and which makes sense in the end. And what about smaller families? You know, that's the other thing, is what about smaller families, or perhaps what sounds like it might be connected, but the relatives were not tested? What do you advise the patient? Well, I think really what you need to also think of is, where can you refer these people that aren't eligible for the government-funded genetic counselling, that is much easier to understand when you've got a large family and you see a pattern. It needs to be evidence-based, and it needs to be reliable, with a genetic counsellor who can not just tell you what gene abnormalities and mutations you have, but also how they appear in the family, and how much that relates to the affected genetic mutation. Because after all, you are going to act upon this with preventative surgery. And that brings me to the other thing that is sometimes asked: what's it like when you're diagnosed with a BRCA mutation? I think on the positive side, some people have a clear family history noted with presentation of cancer running through the family, and they may have a negative test, and we don't know if those people are negative for a mutation or negative because we haven't yet found that mutation, that abnormality. So in some ways, being diagnosed with a BRCA, at least you do know the links to it and what you can do in terms of preventative surgery. And now with nipple-sparing mastectomies, you certainly can have really good results with mastectomies. I'd say the sad thing is looking at early oophorectomy. Certainly it's advised to be 35 in a BRCA1 patient, which, when you think about it, can be any one of you still in residency, you know, or just out of residency, when it's difficult to organize and have a family before that. So I think it really puts the time clock on young people that's very difficult to deal with. I'd say the other thing is that you can cancel patients if they're BRCA positive to that they can have genetic selection in vitro should they choose, and they can also have they can opt to have their children selectively not a BRCA positive. Whether this is a choice that you want is certainly something they can make, but at least it's something they can offer people. If you're BRCA negative in a family of BRCA positive, like my sister and certainly my daughter, who is in medical school in Ontario as well, and there is a survivor guilt sometimes, where why did the person have to suffer so much and yet I don't? So there's a tears of relief, but also there's a guilt of being negative. So it's not without its just plain relief. I think that you go through it as a family, united. In terms of insurance, I think that's been better dealt with nowadays. So I hope this has given you some insight, and I hope that you have learned something. I do want you to be the physicians of the future and to find more of these mutations. We're only finding probably 50%, and we need to increase that. So try looking into people like me who aren't fitting the usual high-risk criteria. And good luck.